Hello and welcome to today's webinar entitled Distinct Health Disparities of LGBTQ Women Experiencing Homelessness. I'm Michael Durham and I will be the moderator for this webinar, which is presented by the National Healthcare for the Homeless Council as part of our spring virtual training series, Her Health, Her Housing, with support from the Health Resources and Services Administration and the Bureau of Primary Health Care. This is a 60-minute presentation with the last portion reserved for Q&A. Please type your questions or technical issues in the chat box below the presentation slides and we will address your questions at the end. If we don't get to all your questions, we'll follow up with the presenters after we adjourn. And if you are having technical issues, you may also call Caroline Gumpenberger at 615-226-2292, extension 222. The session is accredited for one continuing medical education credit hour through Vanderbilt University Medical Center. Please note that the downloadable claim instructions are located in the CME information pod to the right of the presentation slides. If you plan on claiming credit, please download this document and follow the instructions. The claim code will only be available during this session and will appear in the last 20 minutes of the presentation. In order to receive credit, CMEs must be claimed within 3 days of the end of this presentation. Our learning objectives for this presentation are that participants will be able to understand the health and mental health disparities of LGBTQ women experiencing homelessness, identify tools to assess, prevent, and treat specific health and mental health issues that impact this community, and to develop models of engagement and outreach to address barriers to care and access for LGBTQ women experiencing homelessness. Our presenters today are Aruna Krishnakumar, Julie Novas, Phyllis Pickens, and Juliet Widoff of Callum Lower Community Health Center in New York City, and Lazara Paz-Gonzalez from Monmouth University. And with that, Aruna, I'll give it over to you.
Hi everyone, and thank you for all participating in this webinar, and thank you, Michael. The huge number of participants speaks to the importance and interest of this rarely discussed topic. We have an impressive list of panelists, and the goal is to really provide you with all the information and tools that are relevant to your diverse roles, whether you're a medical provider, outreach worker, or public health specialist. As you see in the topics, we will take a look at health disparities to provide context for why homelessness of LGBTQ women is a serious issue, and then dive deeper into medical, mental health, nursing, and outreach strategies for you all to take away. So before doing so, it's important to recognize the dearth of research on this subject. When we look at the precipitating factors that lead to homelessness among women, specifically LGBTQ women, we realize that this lack of societal value placed on women's lives and bodies are the same reasons LGBTQ women are not viewed as valuable bodies to study and to improve their conditions. We'll get into the role of oppression and patriarchy in just a moment. So we have used existing research on women and homelessness and LGBTQ women to provide you with some context, and our panelists can also speak from firsthand experience as practitioners and members of the LGBTQ community. So secondly, in order to discuss this topic, we need to define who we're talking about. For the purposes of today, we're limiting this discussion to cis women, individuals assigned female at birth who identify as women. We're not discounting the many experiences of trans women. Rather, we want to recognize that while trans women experience many of the same types of oppression as cis women, trans women also have specific health and mental health issues, unique experiences navigating systems and the world, and that these are compounded by economic and socio-political discrimination that cis women don't always experience or experience differently. So we are trying to be very specific so as not to paint broad strokes about health and mental health, and also so that we can be better service providers with fewer assumptions. So as we know, cis woman refers to one's gender identity, and there's a range of identities and presentations within this. So one does not have to be feminine to be a woman. One can be butch, non-binary, to name a few. And then we're also limiting this presentation to women whose sexual orientation is not heterosexual. So who are lesbian, gay, bisexual, queer, pansexual, same gender loving, and so on. There are studies that focus on heterosexual women, women who have sex with cis men only, and we want to create a platform for sexual orientations outside of that. My colleague Juliet will tease this out a little bit more to understand sexual behaviors versus identity. So first, we want to just take a look at the landscape of homelessness and see how gender is a driving factor in who is disproportionately affected. So first of all, women and families, of the total number of people living in homelessness, we see that women and families are the highest growing homeless population at 35%. Of the total population of individuals who are homeless, 40% are women. When we look at families, 84% of families experiencing homelessness are headed by women, and 71% of single-parent families who are homeless are female-headed. 60% of them have children under 18 years old. While this isn't limited to LGBTQ women, we do know that children of same-sex couples have poverty rates twice of those of children in heterosexual married couple households. Specifically around LGBTQ homelessness, approximately 9 million LGBTQ identified people live in the USA, and 50% of them are lesbian and bisexual women. Of them, 24% of lesbian and bisexual women are poor, which is compared to 19% of heterosexual women and 13% of heterosexual gay bisexual men. I clumped that all together because there isn't much of a disparity between gay and bisexual men versus their heterosexual counterparts. Now, when we look at youth, 1.6 million youth experience homelessness each year, and of them, over 40% of homeless youth identify as LGBTQ. One more little issue is, we don't want to leave out older adults, and we know that they're particularly economically vulnerable. 28% of them receive government assistance or are living with a disability. So next, we just look at the gendered roots of homelessness, and we just want to focus on a few different issues that really lead to homelessness and are contributing factors. So in terms of, we look at interpersonal violence, mental illness, employment and housing discrimination, and we see that women are really impacted by all of these issues and often lead to homelessness. That's not to say that there aren't other issues like systemic oppression, racism, ethnocentrism, xenophobia, patriarchy, and homophobia. So these are just overall statistics for women and poverty and homelessness. And so I'm going to turn this over to Lazara, who will elaborate a little bit on these psychosocial factors specifically for LGBTQ women.
Thank you, Aruna. And, I think that it's important when we really speak about value and power, and part of the information that you eloquently stated prior when looking at the bigger picture, but when we dissect it a little bit further and look at our specific intended population, specifically for this conversation nonetheless, we really have to take that value and that power into account. And it's important for us, and I know that it seemed like one of the last facts or data that we shared, but when we really look at the impact that it has to look at how many youth are identifying potentially as LGBT and really LGBTQ for the matter of this presentation, and then looking at how many of them, over 40%, and that's information that we capture and actually gets presented. That doesn't always really mirror what's happening in our community, that 40% of this particular population has some form of inequitable home status and or unsteady home life leading to potential homeless. It really impacts the way that we look at the bigger picture and experience some of the broader public health issues that happen. We look at stigma and discrimination, and this, I think, is a trickle effect already from identification at a young age and looking at the way that it impacts. And this is stigma and discrimination not only in our sexual identities, but looking at our status in our homelessness. If we really put them together, we always can identify that, or study has shown, that the biggest piece correlating homelessness to sexual identity is stigma and discrimination. Often it starts from homelessness experienced after being displaced because of being out to family members. It comes with bigger stigma and discrimination in those environmental sectors of our lives, So not only our own personal lives at home, but then looking at our social subsets and then looking at our educational subsets and looking at these other systematic issues that happen. We also see that individuals have internalized phobias of their own that have developed from the stigma and discrimination that come from the status of their sexual identity and or their homelessness. Right? Oftentimes, individuals are experiencing minority stress, and minority stress comes from a process that is both subjective and objective, right? So it's close to or far from that happens internally from experiencing all these identities that come together, right? And as they come together, where do we see ourselves in this lens? Where do we place ourselves in this lens? And how do we feed in to the bigger isms that are happening around us? I think that sadly, disproportionately, poverty and affordable housing has to be looked at as a public health issue. And oftentimes we're speaking about individual events that may be affecting us in terms of our displacement. But when we look at the disproportionate ways in which we access employment, and when we look at just the beginning segment, we are already at an uneven playing field from just identifying as women. We know that women make less to the dollar compared to their male counterparts. Put to that the effect of what it looks like to be able to operate in a broader sense. Look at the fact that affordable housing is an issue. There is not one person in one city, in one state, in the U.S. that can afford to live on their own in the U.S., let alone have to share a space when we are looking at the stigma and discrimination that specifically happens to our communities when they are identifying in the ways that feel most holistic to themselves. So when we separate the issues of income, socioeconomic status, and then the issues of sexual identity, couple them together, it creates a much larger issue. With that, we also see that there are unique mental health needs that happen for individuals who are experiencing homelessness with a diverse sexual identity. So we see that oftentimes, if we're looking at poverty, we're looking at affordability, we then have to also look at health insurance and access to adequate care. When we're looking at that coupled with minimal access to mental health needs, we're seeing a rise in situations that may attribute to the homelessness and then the care needs for this population. We also know that among the population that we're identifying, there's higher risk of substance use, right? And I think that this all goes back to some of the broader issues that Aruna touched on earlier. We see higher instances of sexually transmitted diseases and or illnesses. We see higher instances of cancers because we don't have adequate doctors who are culturally competent and understanding of our needs, not only in our identities, but also in our bodies, and that it looks a little bit different, and that our access is already minimized by all the other issues that are happening on a broader public health perspective. We see higher obesity rates. We see isolation and rejection. As I mentioned earlier, mental health and emotional illnesses and suicide, while compared to the general population, is much higher among females that are of sexual minority. Right? We continue to see heightened risk with violent victimization, whether it be violence from a same-sex gendered partner, whether it be from family, whether it be from outside sources. We see increased abuse and exploitation of individuals, and usually because most often we are seeing that individuals are oftentimes having their fight and flight mechanisms going, we're always in the sense of survival. With survival, we also then see that we are trying to manage the ways in which we operate around the world. We see higher rates of unintended pregnancies, as well as poor childbirth care and outcomes, and there's increased engagement around sexual commerce and high-risk sexual behaviors, again, really attached to the notion of being able to survive and contextualize ourselves in a broader picture within our communities, within trying to be able to get ahead and see the different situations that are happening. We also see that sexual and gender minorities are subject to chronic stress as a result of their stigmatization, as a minority group. As I mentioned before, there is a minority stress process that really affects us internally and externally and shifts the way that we operate within our societies. And these are shared and common experiences of stigma and influence for both our sexual identities, but also for homelessness. And all of that impacts our picture of what health and wellness really looks like and skews the way that we see what potential needs are and even where the gaps are. So, suboptimal medical attention. I finished that last slide with saying that it really does skew our vision of what we see, coupled with the fact that we already have an existing fragmented system, right? LGBTQ individuals face barriers to equitable healthcare that can have a profound impact on their overall well-being. Coming from a place where we're not understanding what our true needs are, we then go into a system that already has existing gaps and doesn't know how to best address some of those needs that are happening. Lack of health insurance or a stable home and income, as well as fear of discrimination from providers, a lack of providers who can actually treat and are well-trained in the health needs of the LGBTQ individual, and or homelessness becomes troublesome and impacts the way that we are able to access and or see, along with the dissatisfaction and challenges in actually obtaining the services, limits the extent in which community access becomes available for health services, right? We see that there are personal issues, as I mentioned, our own internalized homophobia and isms that we experience. There are structural issues, there are systemic issues, there are provider and financial issues. So bring them all together, and we already see that picture that's distorted of what health can look like. There's lack of healthcare provider communication that happens amongst the healthcare community, but also between the provider and the individual. Oftentimes the provider works on a don't ask, don't tell scale, which seems unbeneficial for anyone who's trying to access any adequate health that is efficient and or relatable to the needs of a population. Don't ask, don't tell doesn't work for anyone when we can't communicate what our needs are or the expectations of us being able to get adequate and sound care when we don't know what adequate and sound care looks like. We have seen that data shows that as a whole, individuals who identify as LGBTQ and or females and are experiencing homeless receive poorer healthcare quality. There is stigma attached to it. There's discrimination that's due to the status of the homelessness. There's lack of provider awareness, not only about people's identities, but also around what services to offer when someone is homeless. There's lack of cultural competency in the intersection of these different identities. And there's insensitivity, right? There's misconceptions and perceptions of, and vast assumptions of what it is that people can or cannot have access to, what it is that people need and do not need, and this all leads to inadequate treatment. We know that there are inconsistencies in the way that people access health insurance. We see that oftentimes information isn't adequately documented and or maintained that becomes beneficial. Add to that already existing issues within the healthcare provider sector, where while we hope that most people are working on electronic systems, we still have folks who are operating on paper. And so having to tell our stories over and over and over again, one, creates inconsistencies, but also mandates us to out ourselves every time we go into a different health provider, right? We have a difficult time managing medications by the nature of our social existence and or displacement and homelessness, but also by the other isms that may be happening and or are experienced. And if we're looking at potential violence, whether it be in our home of choice, whether it be through partner violence or any other form of violence, we're also looking at managing medications that are going to take into consideration our safety. So there's a lot to put into perspective when we're really looking at inadequate care, access, and what is available for people. And Juliet, I hand the ball over to you.
Hi there. I think the first thing I'd like to say is just that there isn't a lot of good research and data, that most of what I have to say is just from, expert opinion, personal experience, and what data there is about LGBTQ folks and homelessness is really primarily about youth. There's almost, I could find nothing about adults and certainly not elder folks. So I think there's two main kind of overarching things to think about in terms of health disparities of LGBTQ women. The first is about access, and the first thing is that access is sort of a two-sided thing. Whether folks have access to LGBTQ competent care is extremely few and far between and unlikely, and also in terms of whether due to prior negative experiences or the presumption of discrimination, folks are apt to seek out care. So both there's not a lot of resources and folks are anxious to actually seek out resources because of prior experiences or an expectation of discrimination. Additionally, just sort of generally, I know, as noted previously, poverty rates are significantly higher for LGBTQ women than their heterosexual counterparts, and poverty in and of itself is a predictor of poor health outcomes. And also, within our crazy country's insurance system, there are significantly lower rates of insurance for LGBTQ women due to lack of partner coverage. So across the lifespan, there are certain things that are true. There is, stigma, discrimination, and violence which occur across the lifespan of LGBTQ folks, and it has a really profound impact on health risk behaviors. So there's increased risk of suicidal ideation and suicide attempts. There's significantly more mood and anxiety disorders, higher rates of smoking, alcohol, and substance use. Now, specifically in terms of children and adolescents, we know that they are at much higher risk than their heterosexual counterparts for suicidal ideation and suicide attempts, as well as success. And LGBTQ youth are disproportionately represented among homeless youth. In adulthood, there's also significantly less use of preventive health services by LGBTQ women. Across the board, there are lower rates of pap smears, mammography, and colon cancer screening being done. There's increased risk for obesity and attendant metabolic and musculoskeletal syndromes. There are higher rates of breast cancer, and I just want to be really clear here that that's not because there's something intrinsic to our bodies that is different. That's about risk factors, that there are significantly higher rates of risk factors, which are primarily due to stress and stigma. So the risk factors of cigarette smoking, alcohol use, obesity, and not having children increases those risks of breast cancer. In later adulthood, because LGBTQ women are somewhat less likely to have children than their heterosexual counterparts, they're therefore less likely to receive any care from their adult children. And so that has a significant impact on health and well-being in the later years. Additionally, services for the elderly lag way behind services for the young in terms of LGBTQ competence. And so now I'm going to move on and talk a little bit about what I know about health disparities among homeless women. So one of the main things affecting all folks with homelessness is the disruptions in our lives affect our ability to maintain our health care. So there are frequent moves, insurance status, and change in insurance status. They affect our ability to have continuity of care, and continuity of care is essential for good health outcomes. These constant disruptions and unpredictability make attending appointments exceedingly difficult. One of my fondest prior positions was providing care in a clinic that was situated within a Tier 2 adult family shelter, and it allowed folks just to walk in and actually get care when it was convenient for them. Of course, once they actually were permanently housed, they were no longer able to get that care. So it, unfortunately, although it in some ways allowed for people to receive care in a way that made a whole lot of sense, we perpetuated the system by then discontinuing care once they were permanently housed. There's this slide is from an article by Tarui et al. In Women's Health from 2010. It was one of the few articles I could find that focused on homeless women, and there was absolutely no distinction between heterosexual and sexual minority women in it. And I thought this was an interesting article. First of all, across the board, looking at everyone, there's significantly more history of physical and sexual abuse, more mental illness, more sexually transmitted infections, and more sense of poor health and unmet health needs. But then I thought it was quite fascinating to break it, they broke it down by race, and homeless white women had significantly higher rates than homeless Latina and African American women of across the board poor health. And I think there's what I don't know, having not been the person to do the study, is this due to bias inherent in self-report? There are 1,000 different reasons that people may report differently, partially because of their comfort with interviewers, partially because of their own cultural sense of what they can and cannot say. We know that in general, when we control for education and class, women of color have worse health outcomes than their white counterparts. So it seemed, again, particularly fascinating to me that at least via self-report, these white women had significantly worse outcomes. So could it be that it requires significantly worse health to tip white women into homelessness, or does the experience of homelessness have a more profound effect on white women's health? On the other hand, one might say that does it require significantly less to tip the scales for women of color to become homeless, or do they just have significantly greater resilience in the face of homelessness? Might we see similar differences if there were studies among LGBTQ homeless women? I'm going to move on now and at least talk briefly about what I think is best practices. The first thing to note is that stigma begins when a patient walks into the office. Do the intake forms reflect people's lives? Is heterosexuality presumed in the forms that are used? What posters and magazines are in the waiting area? How are people questioned about their sexual practices and sexual orientation? It's extremely important also that that we distinguish between someone's sexual identity and their sexual practice, most especially when economic pressures may affect what happens in terms of sexual practice. So two main models that I think are essential to be a decent provider to LGBTQ women who are facing homelessness. The first one is harm reduction. And probably most of you are aware of this, but just sort of to generally touch on the important pieces, harm reduction seeks to minimize the harmful effects of behaviors rather than to ignore or condemn them. We have to understand harmful behaviors as complex, as multifaceted, and we have to think about the quality of the individual's life as a criteria for successful intervention. We need to be non-judgmental and non-coercive in our provision of services, and we need to negotiate priorities. And individuals have to have a significant input into their service provision and development of programs. And now very, very briefly, because I know I'm almost out of time, to touch on trauma-informed care, which I know that Julie will also talk about significantly. We have to consider the pervasive nature of trauma and the ways in which it affects all aspects of our health and of our clients' and patients' health, and seek to promote an environment of healing and recovery. We have to think about patient safety first, their feeling of being safe, their ability to have choice in what happens, The collaboration is essential, that we engage our clients and our patients in collaboratively making decisions, and we have to be very trustworthy, which involves being clear, consistent, and having very clear set boundaries. And I think finally, which I know Julie will talk much more about, empowerment is essential. Skill building and really having strength-based assessments. And there you go, Julie, you're on.
Yes. Good afternoon, everyone. So absolutely, trauma-informed care should be the clearing or the rim of all of the work when we approach working with women that are, LGBT women that are experiencing homelessness. And I would just add that as part of the trauma-informed care approach, that it includes recognizing and acknowledging the role of systems and institutions, including all of the isms, as a traumatizing factor or component that women have to experience when engaging and seeking care. Briefly, I'm going to speak about 5 different models or ways of engaging in the care, which starts with strength-based and relational, so focusing on internal strengths and resources of the people that we're working with, and then relationally speaking, helping individuals recognize the role that relationships play in the shaping of our daily experiences, which can then help the folks that we work with to understand patterns appearing in thoughts and feelings that they have toward themselves. And this whole notion, this model, is based on the idea that strong and fulfilling relationships with others can help us to maintain emotional well-being. I know many of you are out in the streets, literally, providing care and engaging with the community, and so crisis intervention is also really important. And just briefly defined, it's immediate and short-term psychological care, and the aim of it is to assist individuals in a crisis situation. The purpose, the wraparound purpose, is to restore equilibrium to their biopsychosocial functioning and to minimize the potential of long-term psychological trauma. There can also be a very a material component to it, with providing resources and referrals on the spot. A third model is solution-focused therapy, which I think can branch off quite nicely from the crisis intervention work. It usually lasts about 3 to 10 sessions. It's brief, it's active, and the focus is more on problem solving and solutions, although there is a space to really identify what's not working, but with the purpose of figuring out solutions. This brings out skills and strengths and abilities that clients already have, which is really powerful because there's a way in which we can engage with our constituents or clients from a deficit model, which only actually does more harm, and people in the face of some of the most challenging experiences of their life are able to tap into internal resources and display resiliency. And so how do we put the lens there? For more detailed skills building, there's dialectical behavioral therapy. A few years ago, I think 10 of us on the clinical team here at Callan Lord completed the 1-year intensive through behavioral tech. This is a model that was originally created for people with borderline personality disorder, but has been found to be super useful for people living with depression, anxiety, post-traumatic stress disorder, substance use, disordered eating, and non-suicidal self-injurious behavior. The focus of the modality is on skills building to manage painful emotions and decrease conflicts in relationships. And it's set up in a way that there are a series of modules. The modules include mindfulness, emotional regulation, distress tolerance, and interpersonal effectiveness. And here in Callan Lord, one unique flavor, in DBT, we talk about invalidating environments and how they can perpetrate ways of being that are not life-affirming. And in our view, we include systems and institutions as part of the invalidating environments. And then lastly, there's tension trauma release exercises. This is a really powerful modality. I'm actually in the process of being trained now. It was created by Dr. David Berselli, and it's based on polyvagal theory. It's a set of 7 easy-to-learn exercises that supports the physical body in completing trauma and completing the trauma experience by down-regulating the nervous system. Often, we are, and the folks that we work with are in a place of fight, flight, or freeze, and are moving through life as if the trauma is actually going on currently, which causes a contraction or a disconnection from the emotional being, from the mental being, from the actual body. So the exercises access the neurogenic tremor, which is common response that we have after a traumatic event. And then the tremors are the innate way of the body discharging excess tension through rapid muscle contraction and relaxation, which calms the body from the excited adrenal state and literally downregulates the nervous system, helps to bring down the blood pressure, the heart rate, etc. So those are just some 5 models, and there's plenty of resources at the end that you can get more information. So some trends with regards to the impact of mental health on LGBT homeless women. Navigating oppressive and gatekeeping systems and institutions is a big thing, and that includes and often starts with the family. Religious, medical institutions, the medical industrial complex, the criminal justice system, and the interplay of other marginalized identities, whether that's like race, age, ability, education, etc. There's also this phenomenon about becoming homeless at a younger age, and it's often due to the LGBT identity. So there's rejection by the family based on sexual orientation or gender identity, being forced out of the house after coming out to parents. There's also this thing about lack of access to, right? So for the youth, lack of access to services in New York, it's around 24, you're expected to have it all together, which, I didn't. Most of us don't. But there's also lack of access to, like, basic hygiene products, like tampons or Diva cups or menstrual pads, as well as Juliet and everyone else was mentioning earlier, LGBT-specific and sensitive comprehensive services. There's also greater difficulty finding shelters that accept and respect the population, and, as was mentioned before, heightened risk of violence, abuse, and exploitation, as well as greater risk for physical and mental health problems and substance use. And just lastly, I want to talk about some techniques that you can utilize both from an emotional mental wellness component or lens, and then from a spiritual lens as well. So emotionally and mentally, there's, being present, right? So that looks like eye contact, body language, being mindful of these things that give nonverbal cues to the folks that we're working with, utilizing validation and really validating what's valid. This doesn't happen often enough, and there isn't often an acknowledgement of the resistance and resiliency that lives within the population. Motivational interviewing, which is really supportive, especially if someone is in the contemplation of creating a change in their life. This is a way of really being able to engage with the person to start really unpacking what's happening and how would you like to move forward. Some other techniques are reflecting and paraphrasing. This is a way of people being able to feel heard because you're kind of literally reflecting back like a mirror what was shared. Sometimes the opposite is necessary, so something like countering, which is kind of a gentle pushback on what's being said, and DBT we would call it like checking the facts, like is this so, like is it so? Reframing, so there's a way in which we can name our experience, but if we're not feeling the most empowered in the moment, we can frame it in a way that then further disempowers us. So this is the support of like reframing what's so in a way that's more life-affirming and positive. Of course, problem solving, and then use of self when appropriate. And the caveat with the use of self is to always ask yourself, is what I'm about to share about myself in the purpose and interest of moving forward and or supporting the person that I'm working with, or am I just sharing to share? If it's sharing to share, don't share it. If it's to move forward and support your client so that they don't feel isolated, so that they're like, oh, I'm not the only one, etc., then that's definitely appropriate to share. And then as far as spiritual wellness, I have the tremoring from TRE, which I think could also go under mental and emotional, but there is a spiritual component. In the parentheses that I have baby shakes, this is a euphemism from Urban Athletics. I was trained in emotional release work. And basically it talks about how when we're born with very concrete ways of taking care of ourselves. So just think about, what does a newborn baby do, right? So they cry, they laugh, they giggle, they, release, literally. There's mindfulness meditation, so grounding the awareness in the breath, right? In sounds or even in feeling tones. and by feeling tone, all emotions fall under a tone of pleasant, unpleasant, or neutral. So being able to name the emotion, the tone of the emotion as it's coming up, can give some space so that we don't get hooked and then act out of reactivity. Self-soothing with the 6 senses is part of DBT. And it's the traditional 5 senses and movement as a way of bringing care and ease. So how do you engage your senses, whether that's visually, through the sense of smell or taste, etc. Self-massage, which can also be very soothing. Affirmations and inspirational cards. So I have these and I end sessions with these every session, and it's just a reminder of your innate being and who you truly are that often clients post, or keep in their wallet to remind themselves of the work and their true essence, even in the face of a marginalizing and oppressive society, of who they truly are. And then lastly, wellness kits. You can include anything there. Usually from a spiritual perspective, there will be essential oils or crystals, things to nourish yourself with, herbal teas, and maybe a little deck of cards. So things that you can pull on when your internal resources feel low to be able to support through a challenging moment in time. So with that, I will turn it over to Phyllis.
Thank you, Julie.
You're most welcome.
Okay. So I'm going to be talking about some of the ways in which we deliver care on our mobile health unit and in terms of reaching homeless LGBTQ young women. So a lot of our approaches are around screening and treatment for STIs and HIV when we go out there. And I just want to say also, too, even though this is for my outreach is on a mobile van, it's outreach for anybody. Tools that I'm talking about as a nurse are tools that can be used in your office, on the street, wherever. It's just being sensitive to where you find your client to be at, okay? So some of the symptoms that they complain about are about vaginitis, lesions that they may get when having sex, sometimes herpes and tears that they may acquire during sex. Vaginitis can be around trichomonas, chlamydia, gonorrhea, and BV, vaginosis, things like that are some of the concerns that they have, yeast infection as well. And so sometimes that does require them to obtain genital care. Just want to make a note to say that in doing genital care, you have to assess the need for a pelvic exam and explore their readiness for that. Oftentimes youth have been through tremendous trauma in their lives, and this can be considered invasive for adolescents who are having the exam for the very first time, or survivors of incest or sexual violence. So have a little talk about that, try to make that examination comfortable, and always reassure them that when you're doing it, that they can say stop at any time. That's so important. Pregnancy testing is often offered to women. Sometimes before you give medications, you want to make sure they're not pregnant. Assess their history for having sex with cisgendered men and trans women. That's important. Sometimes they may never have had sex with a man or a trans woman, and so is it necessary to do a pregnancy test? So just having a conversation. I'm not saying, because sometimes, we have to do it for our documentation, but say that to the young person that I'm doing it for documentation, not to indicate that you didn't believe that they never had sex with a male, a cisgendered male, or a trans woman. So how do we utilize the mobile health to reach homeless LGBTQ women? We do a lot of prevention and health maintenance. In our prevention, we talk about safer sex for lesbian, helping them to create safer sex kits that works for them, which oftentimes utilizes finger cuffs, dental dams, gloves, saran wrap, female condoms, whatever works for them. I also should include, sex toys that they may use, how to properly clean them and prepare them for use before sex. When they're using their fingers, what
what parts they're using, you know, being careful not to go from anal to vaginal, things like that should be educated, you know, because sometimes people are trying to use the lubrication that's around, and so having lube on hand is important so that they could do that. And also using latex gloves is another thing that they should be aware of. And I just want to say, too, that oftentimes lesbians may feel that they don't need to worry about safer sex or using safer sex materials, but if you really don't know your partner for the last 6 months in terms of their sexual history, what their STI history has been, who they've been with, this is a good way to begin getting started, having that talk with your partner about that and saying, you know, let's start off with safer sex until we know more about each other. And that discussion adults have problems with, so adolescents will have problems with, because sometimes they think it will interfere with their ability to trust their partners. But it's important to help them learn to begin doing that, because it may help them with acquiring infections that they wouldn't need to otherwise have gotten. Another thing that comes up, we also teach about breast self-exams. You know, women have higher rates of breast cancer as they get older, so when teaching them when they're younger how to get comfortable with their breasts, what it feels like, any lumps that develops, it's a good habit to have when they're in the shower, and so we talk about that. And we update vaccinations as well as giving hepatitis A, B vaccinations, checking them to make sure they're immunized, and we also screen for hepatitis C in case people are involved with people who have sex or people that utilize injection drugs, having sex with people who utilize injection drugs. Other things come up on with clients is dealing with chronic illnesses such as asthma, type 2 diabetes, and anemia. And when you're dealing with chronic illnesses, good understanding is to be patient with this process. You might find that they don't follow through on instructions on self-care or management of their health regarding these illnesses. And you just have to be patient in such a way that you can encourage one lifestyle change at a time. Being homeless requires tremendous navigation on the street, maybe couch surfing or floor surfing in people's homes, or just trying to get through the next day. That can be very difficult, and so that's what their minds are on, like where I'm going to sleep the next day, where I'm going to eat, how I'm going to manage, what I'm going to do the next day. So to think about if you're dealing with a diabetic, just having to think about, well, how's my water intake? Maybe that's something I can work on. Wherever I go, make sure I'm drinking water as well. So just think about one goal that you can in your relationship with them to achieve. And when they achieve that goal and they talk to you about that, praise them for it, because that's a step in the right direction. We also give first aid for like injuries that they acquire through accidents that can happen in the street, you know, fights that goes on, things like that, teaching them how to do wound care. And also teaching them about their bodies. That's very important because there's a lot of myths or cultural understandings about how the body functions, and when they talk to you about it, you might want to be able to dispel those myths or cultural misunderstandings. But recognize that those cultural understandings came about for a reason, and not to say that that is wrong, but just know the facts behind why it may be happening. You want to be able to provide basic needs such as food, hot tea, cocoa in the winter, providing personal care items, as Julia talked about. Certain things are very hard to get out in the streets. You know, female needs are often not present in bathrooms, and so being able to make sure that they have these things is important, and set up for that. Place them in your bathrooms, at your office, you know, tampons, things like that is very important. And then just a little hint to a little psychosocial assessment. Things that are important to do is that you want to know how are they surviving on the streets? What issues are they facing? Are there any safety concerns, domestic violence, power dynamics in relationships? What employments are they trying to obtain, and education? And also talk about creative employments. Just briefly, I was watching on Facebook about this lesbian couple that's been taking on driving the trucking business. And they both learned to get their CDL and et cetera, and through Amazon. So, there's companies that will train people to do it. You're committed to work for them. You can't have a schedule of being here and there. You got to be committed to them all together, and my time is almost up, but that's an option. Think about what jobs they can do that will work for them while they're on the streets. And then you want to think about who's in their community or their chosen family. That's important. The goal is to provide care that addresses the whole person in a culturally sensitive, non-judgmental, and caring approach. And providing visibility of LGBTQ community is important to have representation of the LGBTQ community because it creates an open space for them to tell their stories and talk about their lives, fears, and health concerns. And the other and most important thing is that you should be comfortable with discussions about their sexual history, health concerns, relationships. It's all vital to your work. And being in touch with what are the issues you're dealing with. If it brings up issues for you, be in touch with that. Talk about it with your colleagues so it doesn't come into the room with the patient and you're clearly working with the patient. There's so many biases that come up that creates a distance of a patient being able to access services. And if you come off in a way that they feel they're not being heard or not listened to, that can dispel them from not coming back. I think we're successful because is that we also try to maintain relationships through trust and confidentiality, and that helps them to keep coming back. Thank you for giving me this time.
So what does this all mean? I think that all of the speakers, all of us who have been on the line and been able to get the message across have been trying to say that health is really put together by many factors, and so many things really influence it. And we have to understand that the role of geography, race, ethnicity, socioeconomic status, our gender identities, the way we even want the world to see us, really come together to provide a combined effect on our interaction with health, our understanding of health, and really the way that we see health and or the things that are available to us. Remember that there's gaps in and barriers to social, housing, and medical services, and that they're rampant and still remain. Most efforts that we've spoken about initially have focused on youth. We talk a lot about the realities, the disparities, the resources that are available to youth, and often forget that there's this age at the point of 25 where almost everyone starts aging out of services, and that the gap becomes even bigger for what becomes available. So being able to influence the way that we work within our agencies, the services that we offer individuals, is important because we're coming from a shift in being served as a youth, potentially, and knowing that there is a safety net and quote-unquote then aging out and being faced with not having supportive systems that can really support us being able to thrive. Also remember that not one size fits all. Everyone has different needs. Everyone is one individual that comprises a beautiful net but has individual needs. There is a different way that services then also impact long-term homelessness versus acute homelessness, which is a question that we didn't even completely dive into, right? That sometimes the need for someone who may be marginally displaced or displaced for one episode is different than an individual who may be having long-term needs and or long-term homelessness. So understand the individuals that you're working with, understand the populations that you're working with, and take it a step further. Don't only understand your people, really understand the resources that are available to your people as well, right? This is part of really being culturally humble and being able to go beyond just culturally competent in understanding, but knowing that there's this evolution in our understanding of what things look like, right? Also remember that there's complex interplays between sexuality, sexual identities versus sexual behavior, that sexual identity sometimes has nothing to do with gender and or gender presentation. Remember that also interrelated into this beautiful web that we call our lives is our ethnic cultural identities that sometimes go hand in hand and sometimes separate every other little piece of us and how we present to the world, and know that there's also different needs for different age groups, right? So back to not one size fits all, that we have to tailor services, resources, and or the ways that we approach our population based on individual needs that each individual may have. And throughout our conversation, we've discussed a number of ways that we can address some of the, I'd say even surface issues, because this conversation could go on way more than an hour, but that understand the individualities of individuals. Juliet mentioned to look at harm reduction models in trauma-informed care. I can't express that enough on the importance of being able to really meet people where they're at and look at harm reduction way beyond just a substance use model and really a day-to-day practical model to be able to offer services. Julie mentioned that we should reframe and shift the paradigm, and I think that's critical to allowing us to be able to really work on people and allow folks to genuinely identify what they need, no matter how much we think we know what they need. I don't want to take any more time because I do want to allow for a few minutes of question and answer, but thank you for this opportunity, and I guess we're opening it up the floor.
Thank you so much, Laz. We have just a couple minutes for questions before I conclude with a couple of logistical things. Before we do that, I do want to remind everyone that if you intend to claim CME credit, there is a box on your screen called CME instructions. You need to click on that and download the file to follow those instructions, and then copy the code that's on your screen. And then the instructions should help you from that point on. Thank you so much to our presenters today. I learned a lot. I think we delved into a really big, complex issue. I'm only going to have time for one or two questions, so I'm going to ask Laz to address the one that we got, to explain a little bit more about what you meant about medication management and violence. Can you take a moment to address that one?
Yeah, sure. Thank you for asking that question. I think that when looking at inherent risks associated with possible homelessness, we see that violence is one of the biggest concerns. I think that we've spoken about that in many ways throughout our conversation, and also by the nature of being homeless, there may be some instability in safekeeping of medications. You know, look at lack of storage. Sometimes look at the need to sell medications to gain income, right? Look at the ability to pay for the initial medications and or medication management. And all of that goes into the way that we are able to maintain that medication management and how the risks associated with being homeless, violence being a major part of it, may come into play. And I'm hoping that that answered a little bit of the question, but I'm happy to reply back something that we may be able to send out to the person.
Okay. And again, the questions that we don't address, we will email to our presenters and log those responses when we put the recording on our website. Let's do one more. There was a question earlier on about why we did not include trans women in this presentation. And we addressed it a little bit in the Q&A pod on the screen, but I'm wondering if anybody at Callan Lord wants to just kind of address the nuance about the pros and cons of including gender identity within the broader LGBTQ acronym.
Sure. So this is Aruna. So, I mean, we really wanted to be conscious of the fact that trans folks have very distinct experiences, and so it's not that we are defining women in this way. We're just really making it more specific in terms of who we're talking about for this presentation. I think we really want to recognize that trans women have, deserve their own presentation, really, more than an hour, and these experiences are very specifically about cis women who are LGBTQ identified.
And there is going to be one on trans women, correct?
I
or
believe so,
trans
yeah.
folks.
Yeah. Is that right, Michael?
There isn't in this session, but we have lots of materials on our website specific for trans folks. So that's that. We do need to wrap up. I want to acknowledge that our presenters put a ton of resources on the last couple of slides, which will be archived on our website. And I do want to give a shout out to the next sessions in our webinar series. We've got 4 more, so we're halfway to go. Next week we'll get into racism and women experiencing homelessness, which we addressed a little bit today as it relates to minority stress. And then we'll also get into services for pregnant women experiencing homelessness. So we're excited about that. We hope you'll join us. One last reminder to copy and follow the instructions to claim your CME credit for this session. The claim code will only be available now, and credit must be claimed within 3 days. An evaluation of today's presentation should automatically appear in your browser when the webinar closes. If it does not appear, please copy and paste the link provided on the closing page to access the evaluation. Thank you so much to our presenters again, and for everyone who joined us today. I'm really appreciative, and I hope you have a great rest of your day and weekend. Thank you. This webinar